Hi, everyone. Welcome again to day 2 at HIMSS. Welcome back to the main stage, sponsored by CGI. Very excited to introduce our next panel coming up on stage here in front of you, discussing bridging the gaps. Please a warm round of applause for our team from the US Federal. Thank you.
Thanks very much, Ben. Is the mic on? Can you all hear us? All right, good. Well, I'm Dr. Jim Peake, and I'm joined here today with Dr. Sean McNamee, who I'll introduce a little further later. Randy Tharp, who is our Vice President for Business Engineering, and Kay Liyanage, who is a longtime CGIer who's been working in the HHS environment. You might think we would be talking about AI because it seems like that's all you see around this floor and probably all you've heard. In fact, it is really the buzz. But when you think about it, it's been around for a much longer time than kind of you would gather from this being the hot item, right? In the 1940s, the deep neural networks were first envisioned. In the 50s, they were implemented. Then you had deep learning come around in about 1980s into the 2000s, where you had multiple levels of neural networks working. But frankly, I think it was November of 2022 when ChatGPT got introduced that it sort of opened AI to the masses, to the non-technical people like even me. And people are starting to find uses for it. So even though it's been a long journey, it is, I think we're in the early stages of that journey, really, from what we can get out of it. I think it's really worth remembering that fundamental to AI and any of the insights and value that we can get out of it, it relies on the underlying data. And it's the quality of that data, how that data is transmitted, how that data is amassed, and how different data sets, whether it's structured, unstructured, images, are be able to amass, to be able to leverage AI on top of it that is really going to yield the value. So I think that is a particularly important aspect of this. And when you think about all the challenges that we face in healthcare today, everything from bureaucratic inefficiencies, I know that everybody here has probably faced some of that, to workforce shortages, to diagnostic decision making, are things that all of these things are things that AI can actually help with. And so the importance of starting with use cases and not just going after the hype is something that I think is extremely important here. I think it's great to be able to learn lessons from people in the field. And when we have a representative from the largest integrated delivery system in the United States of America, the VA, I think it's really worth listening to the challenges, to the opportunities, to the direction that they will have, because I think it's going to help shape the rest of civilian medicine as well. And so, I met Shane McNamee, I don't know, it was many years ago when I visited the VA hospital in Richmond when I was Secretary of the VA, and he was running the polytrauma center there. So he's a clinician. We were seeing lots of casualties back from Iraq and Afghanistan during those days. And we were exchanging them between the military health system, where I'd been the Surgeon General before, and with the VA, and doing remarkable things for our patients. But he's gone on to be an informaticist in the civilian sector and the public sector, and is now back at the VA as the senior advisor to Jonathan Nepiker, the CMIO of the VA. So, Shane, thank you for being here, and let me turn it over to you.
Thank you, Secretary Peake. It's an absolute honor. You need to know that, and I think I tell you that every time I see you. I always call him my secretary. 20 years ago when we first met, I guess it would have been, I had a head full of hair. I had 2 young babies. We were in the midst of the OEF and OAF conflict, and a river of severely wounded service members and their families were flowing from Walter Reed and Bethesda into our polytrauma unit at the Richmond VA. We had an incredible amount of need to be able to support these wounded service members with wounds that people simply didn't survive in past conflicts. And we were benefited at that time by having a secretary who not only cared and not only visited, but got Congress to open up the checkbook for us in terms of getting us whatever we needed whenever we needed it. Inside of about 5 years, we went from a single hallway up on the brain injury unit to 3 buildings across the campus that covered coma recovery units, to traumatic brain injury, to transitional rehabilitation, to vocational rehabilitation, to do this thing that we like to call turning patients back into people, right? This ability to say, okay, how do we take you and your family members after this horrific thing, and how over time do we help you rebuild your lives? An incredible time, right? And I always thank you for the support, because we couldn't truly have done it without you. There's a guy wrote a book about it. Read it. It's called Hope Emerges, the unit that we built there. And what I'll say at the end of it is that we performed miracles there. And I don't mean miracles and like the doctor miracles. I happen to be a physician. We didn't give people fancy pills that other people didn't have, or therapies that other people didn't have. We had the time, we had the mission, and we had the resources to help every single one of these patients and their families unpack what happened to them and help them rebuild their lives over time. And because we could truly care for them, right, in something we called relationship-based medicine, not the medicine where you step away from and put space in between, but you get involved and engaged with them and got to understand them. We had 2 babies born on the unit. We had a wedding that I walked the mother of the bride down. We had divorces, everything you can imagine. But because we as healthcare providers and our rehabilitation teams had the resources and the time, we were able to solve some of the most challenging healthcare cases you could imagine and put people back in their lives where they felt valued again. So how does that have anything to do with AI, right? How does that have anything to do with health information technology? I remember very clearly thinking back then, if only we could take this level of resource, veteran focus, responsive, reliable systems, why can't we scale this across our entire system of care, not just in the VA, but also in the private sector? Because of resource constraints. We don't have enough people. The people that are working, the healthcare teams and the population health teams, don't have enough time, right? Because in the last, 20 years of this digital health revolution that we have journeyed along, we as clinicians now spend between 60 and 80% of our time during the day tending to the needs of the computers. We are the automation widgets. We are the agent AIs that have to continuously connect everything together. I like to think of it as an old-fashioned telephone operator where you're swivel chairing between and connecting in between. Well, what does that do? That takes your caregivers, right? Instead of scaling our caregivers and giving them the tools and the supports and what have you to do their jobs better, we in this first half of this digital health revolution have become overburdened. There's a series of points of care solutions that come down, that every one of them does a great job for that piece of care, but then it's up to us to coordinate all of those things together, right? So the reason I took a left turn into health information technology, informatics, and everything else was to look for opportunities to use technology to cover up our human cognitive weaknesses and scale our workforce so we can close the laptops and make eye contact with the people that we're actually serving, right? So jumping from there into automation now feels like a pretty straight line, right? How do we then take these automation technologies, both the case management process automation, the tubes in the sky that the patient flow through, how do we take those and then start to use AI, but even more specifically, agent AI to be that extension for us. So we cannot keep pace with I think it's medical literature doubles every 37 days now. We can't keep pace with that. It takes 17 years to take best practices and move them out in the field, right? That's not good enough for anybody here, me as a patient, me as a clinician. But the Secretary knows I'm oddly optimistic when it comes to these things. As we start to hit agentic AI, in particular, generative AI is fine. I love predictive AI because it can really help us hone down on the populations we serve. But as we start to hit agentic AI, those are the tools that we've been dying for over the years. Those are the tools that can start to give us efficiencies back in our workflow. And if you're a believer in the theory of constraints, aka automation, we know that efficiency is that what we have to harvest first that drives downstream health quality. So I'll say in terms of what we're doing these days in the VA, we have a very rich profile of AI applications that we're now starting to bring out in front of clinicians one by one, making sure they're safe. But we're also building the infrastructure so that these tools aren't a one-off, but that they coordinate together. And then the governance, which is incredibly necessary to make sure that we're doing the right thing over time and that we're meeting the care needs. So it's an exciting time. These technologies, and I'm not a technologist. I was a philosophy major in college. But so I don't believe that technology save us, but I do believe that times come along when technology can significantly change the course and the quality of whatever industry we're in. And we're in one of those times, right? But we also have to, this is my last point, we also have to be a little bit patient. We come here and we see, and everybody's talking about AI and these agents and whatnot, and we want to take them and we want to plug them in today. In 3 years, these solutions are going to be unrecognizable. We're going to go from a Model T Ford, I was going to say a Tesla, I'll say to a Tesla, right? In about 3 years, right? Or whatever your favorite electronic car is in the next 3 years. So we have to be smart that we're not just grabbing the first things, but we're building the appropriate data infrastructure so we have the data coming in that's clean and the governance infrastructures to give us agility back in healthcare. That's my hope.
Thank you very much. Randy, from your experience now working in the civilian sector, in the VA sector, let me turn it over to you.
Yeah, and first, I didn't know you were at Richmond coming out. I was Army veteran, 2 tours to Iraq, and I had multiple TBIs. And my last tour of duty was at Walter Reed getting out. So, I was very appreciative of the care I received and the care I still receive very heavily from the VA. And it was during that time transitioning out where I wanted to devote my life to helping veterans in the system. Seeing doctors struggle with trying to read the JLV and put in my patient data into Vista, it was painful. I sat in there for 15 minutes before she even asked me, anything about my systems.
Exactly.
And I wanted to help that. And so being at CGI, I have the unique opportunity to work with our global team. Many of them are here at our booth. I encourage you all to stop by. Really, really smart experts. And we are together on what we have as a Health and Life Sciences Council, where we work together every week on global innovations and technologies, supporting exactly what we're talking about here. The challenges we have at VA is not unique to VA, right? We've been working on these for decades across the globe. So when you think about some of the initiatives we're working on, one of the biggest is imaging, integrating imaging platforms, right? You have various modalities and sources coming in, and as a personal example, I recently had an MRI done, and I had to go out to a provider in the network. I had to carry the CDs back to the VA, give it to somebody in a basement. They didn't have the software to upload it in the hospital, so they had to mail it to a different hospital, and then that went into an imaging software, but they didn't have the doctor there to read it, so it took 10 weeks to get MRI imaging results. But CGI is fixing that, and it's exciting to be a part of. Just in Sweden, we created for the largest region there, and have over 1.5 million patient encounters across 200 provider organizations, bringing in imaging data into a unified platform. I mean, the power of that is incredible when you think of patient and provider experience and the nuts and bolts of actually getting care and seeing your imaging. It's just incredible to be a part of. So I'm glad you're back at the VA, working on very important initiatives, and be a partner with you, and I'll turn it over to Kay.
Thanks, Randy. So my name's Kesara Liyanage, and I've been working in healthcare in the federal space for 17 years, which is my entire career. You can feel free to sing Kesara Sara to me if you're good at singing. But in working so closely, in particular with the CMS mission, what you really see is the dynamic interactions that happen between providers, payers, and beneficiaries, and the challenges that exist in that, actually evolving challenges that exist in the healthcare system, right? One thing that I came across, a lot of my friends are physicians, and they tell me they spend over 6 hours a day doing redundant activities and administrative tasks, right? And I interact with payer systems, and they tell me that they deal with a lot of inaccurate claims data, that they struggle with improper payments, and when you talk to the beneficiaries, which I do a lot of when I go to conferences, they talk about their concern with the quality of care that they're receiving, and also the transparency in their treatment, right? So every single kiosk almost here has AI, and every government agency has AI in their strategic objectives. And while it's important to be bold and future thinking and forward thinking in how we think about AI, I think there's an urgency now to utilize this technology to solve the real world problems that beneficiaries, payers, and providers face today. And Dr. Peake touched on this, and it's that utilizing data-driven decision making is really the path to creating a solution that builds more automation, right? Streamlines manual processes and provides the kinds of efficiencies that organizations look for today. And another reason to really think about the data first is to go back to what Dr. McNamee was talking about, which is you need this technology to be able to evolve over time. Today's solution really becomes dated. So if you have the correct data, you have the correct interpretation and the business rules, in enveloping technology on top of that is scalable, right? So, another thing that the panel here talked about was AI is no longer a buzzword. In CGI, we've invested, over $1 billion in emerging technology, right? And when we think about our investments in AI, it's really designed to solve today's problems. We're in over 40 countries. So we understand that AI is being globally implemented as practical solutions now, right? It's not a buzzword. It's a real solution that's happening. And what we do best is we use our insights from the global practice that we have, and we bring ideas and solutions to the federal healthcare system and just generally overall the U.S. healthcare system. And there are things that I'm genuinely excited about within the federal healthcare space that I want to touch on. One of the things that we're very interested in and want to spearhead with CMS is the idea of automating pre-authorizations. I was looking, I was kind of reading into this a few years ago, and I was looking at this, and it sort of said that 70% of pre-authorizations take over a month for approval, and pre-authorizations and the concept of ordering, and treatments really also correlate into improper payments. In Medicare, CMS saying there's over 8% of Medicare claims have improper payments. That's billions, if not tens of billions of dollars in waste that's happening. And CMS has recently invested in simplifying the fee-for-service requirements that are out there so that it's more accessible and understandable to a provider. But I think there's more that we can do with the technology that exists, right? I think you can use AI, LLM, and data standardizations like FHIR to bridge EHR data with the simplified understanding of payer requirements. So when a provider looks at a beneficiary's Medicare medical record, they can understand the data better. They can understand what treatments are covered before they actually order a particular treatment. Right? I had a situation where an MRI was ordered for me. Well, it wasn't covered, and I ended up paying like $3,000 for it. Right? So if we are able to integrate, in which we can, the data from the requirements from a payer with an EHR, and utilize the data from the EHR to understand when a particular order may be denied later, a claim could be denied later, you can upfront alert the particular provider or the financial area within a healthcare system before a claim is even billed. And if everything checks out, if the requirements are aligned with the treatment plan, with the payer policies, streamline that payment, pre-authorize it, so that those manual workflows that exist currently in the claim systems, become more streamlined and efficient. Right? So this is an area I think that we have to move into. It will yield not only more informed treatment, but better overall care to beneficiaries. And again, talking about data, another area that I'm working with is with the NIH. They are very interested in utilizing data from wearable tech. We all wear, Apple Watches. I actually, through this program, got super into like the Aura ring and went and bought one, and I live and die by those stats every day. So, the NIH is really interested in harnessing that data, that public health data, and standardizing it so that you're able to better understand conditions, do predictive analysis to better understand and preemptively be able to diagnose, issues that may be there, and be able to cater treatments and research towards treatments. So that is an area where I think it's the emergence of technology with data that really governs sort of this future of this seamless healthcare integration. And I think the final thing that I'll touch on here is we're federal contractors, right? We have federal clients, and we know that now more than ever the government is asked to be more efficient, right? And reduce costs, identify waste. But the challenge there is that I work very closely with CMS. Well, the need to be agile to policies and the needs of the healthcare community doesn't change. All of a sudden, that doesn't go away. So as federal contractors, we bear a responsibility to provide our clients with efficient solutions. So something that we've started, implementing in a lot of our healthcare projects, and we're seeing a lot of results, is sort of the integration of AI assist tools. And this is designed to automatically generate code, to simplify testing, and also just overarchingly build efficiencies in a development cycle so that we can do more for the federal government, allow them to be more agile in how they implement their policies. And we recently did a prototype outside of healthcare, and by implementing this, we were able to automate code from wireframes. So the developers aren't spending tons of time interpreting requirements. It's fed in through this assistant tool. And we were able to deliver that prototype successfully with all the features that the government was looking for. And another area is with this large healthcare system that we are maintaining for the government. And we do over 200 enhancements a year, right? And that's because Medicare policy requirements change consistently. And we're able to use this technology to deliver more products, more enhancements into our systems at a more efficient and scalable way. And what that all comes down to is the federal government can now be more efficient. The federal government can actually provide the levels of service and meet the overarching efficiency that's being tasked of them. So, to kind of wrap this up, when I, again, thinking about seamless healthcare and how we integrate AI, it's thoughtfully, it's effectively, it's thinking of use cases and finding practical solutions while making those solutions agile to the future. You start with data-driven decisions because we know that works. And you build upon that and you envelop technology such that you solve today's problems with more automation, streamlined workflows, and building the efficiencies that ultimately results in better patient care. Thanks.
Hey, thanks very much. And I think we've got a couple of minutes. So Shane, I'm just curious if, in terms of your thoughts about the data and how, and within the VA, what are some of the opportunities and challenges of getting the data together that can feed the opportunity to get different insights about our patients and about the system? Because you've heard there's the admin aspect and then there's the clinical aspect, and they are both opportunities, I think.
Sure. We're a bit of a victim of our own success in our interoperability initiatives. Dr. Nebeker has led over the years for us. We now connect to 90% of all healthcare facilities in the country. We have about 100,000 that we connect to. We exchange 350 million documents per month, which is great until you're a primary care provider. More data isn't always the better, right? We've reached a point where the amount and volume is simply too much to consume and to use and to understand. And then when you get into the variability of the quality of the data that's coming in, whether it's incomplete or the wrong field is in the wrong place or the wrong numbers are in the wrong place, the challenges of using that, number one, is humans to aggregate, collate, normalize, standardize it all into your head, come up with the information that's necessary, and then plug it back into all the machines. Every day gets harder and harder and harder, right? So some of the initiatives that we're leaning into and Jonathan is pushing on are data quality automation and assessment initiatives. If you haven't seen the Peake framework, the PIQI framework that's coming out right now, something the VA and Levitt Brothers are getting behind as an open source community that allows us to assess the quality of data packets effectively, regardless and agnostic to the type of data that's coming through, so you can have runtime data quality assessments. And what that then gets us to is, once we get to a high quality of data, it's then computable. And then we can use computers to compute it and to help us in our jobs on a daily basis, rather than constantly feeding today's punch cards into the mainframes that we use, right? So data quality is incredibly important. Or, as Jonathan liked to say, it's not just about the pipes, but we need to make the water drinkable too, right? So we've extended the pipes, and now we're putting in, hopefully as time goes on, with industry, lifting the ability to automate data quality assessment as it comes through.
I love it. Well, here's to drinkable water. Thank you all very much for coming, and look forward to answering your questions if you put them in the chat or send us a note.